Sir, good evening, sir.
Good evening, Tarak sir. Good evening.
Sir, good evening, sir.
Okay. I hope everybody is ready with your presentations. Dr. Khyati, are you here?
Yes, sir.
Dr. Pranav, are you there?
Yes, sir. Ready, sir.
Very good. And our examiners are already here. Welcome, Dr. Venugopal Reddy garu. Welcome, Dr. Sirisha garu.
Good evening,
Good
sir.
evening, sir.
Good evening. Good evening. I hope both the mentors are. Dr. Danya is here. Welcome, Dr. Danya.
Thank you, sir.
The other Padmapriya madam, are you here?
Yes, sir.
Yeah. Welcome, madam.
Thank you, sir.
Yeah, see, I'm still getting messages that the link is not working. uh, okay, I think we can start. It's 8 o'clock, and let us start our webinar. I welcome you all for today's Andhra Pradesh Ophthalmological Society ARC's short cases webinar. This is we are having our case number 9 and case number 10 right now. So we have with us Dr. Khyati Ganesuni. She'll be presenting a case of third O palsy, and her mentor is Dr. P. Padmapriya from Assistant Professor from Katuri Medical College and Hospital at Guntur. And we have Dr. Pranav. He is second year DNB PG from Sodasni Hospital, Guntur. And his mentor is Dr. Danya, vitreoretinal surgeon from Sodasni Hospital, Guntur. And most important people, our examiners is Dr. G. Sirisha, Professor and Head of Department of NRM Medical College, Department of Ophthalmology at Guntur, and Dr. Y.C. Venugopal Reddy. He is a Senior Medical Consultant and Vitreoretinal Services at Sri Venkateshwara Arvindaya Hospital, Tirupati. I welcome all of you, and without wasting much time, I think we'll go ahead with our first case from Dr. Khyati Ganesuni, case of third no palsy. Dr. Khyati, share your.
Yes, sir. Sir, am I visible?
Yes, you're audible.
Yeah.
Yes.
You're audible, and yes, your case is also.
Good evening. My case is a 67-year-old female, Taluri Raunamma, who's a homemaker by profession. She's come from Koratipadu, Guntur, with complaints of drooping of left upper eyelid since 4 days. History of presenting illness. She was apparently normal 4 days back, after which she developed left eye upper lid drooping, which was sudden in onset, progressive, painless, with no diurnal variation. She also noticed double vision in her left eye, which was manually, when she lifts manually her upper eyelid, which was sudden in onset. No history of pain, redness, watering, glare, photophobia, diminution of vision. No history of ocular or head trauma. Not associated with headaches, loss of consciousness, or seizures. No history of hearing loss or ear discharge. No history of limb weakness, tremors. No history of slurred speech or deviation of mouth. No history of memory loss or sleep disturbances. Past history, no previous episodes of drooping of eyelids or double vision in the past. About 20 days back, she was admitted for 3 days and treated in a local hospital in view of low-grade fever with no diurnal variation and associated with nausea and vomitings. She did not have her treatment records, but her investigation showed normal CFT, CBC, LFT, and RFT, and RBS of 364 milligrams per deciliter. Medical history, she is a known case of type 2 diabetes mellitus since 6 years and was previously treated with oral hypoglycemic agents, but changed to insulin 20 days back. So she is currently now taking subcutaneous human mixtard 20 international units BD. She is also a known case of systemic hypertension since 2 years on regular medication. She is a not known case of coronary artery disease, cerebrovascular accidents, bronchial asthma, epilepsy, and thyroid disorders. She has a history of both eyes cataract surgery done 3 years back elsewhere, and history of abdominal hysterectomy 23 years back in view of abnormal uterine bleeding. No significant family history. Personal history, she takes mixed diet, sleep and appetite are normal, bowel and bladder habits are regular, non-smoker and non-alcoholic with no history of tobacco chewing. General examination, she is conscious, well-oriented to time, place and person. She is moderately built and nourished. No signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy and pedal edema. Vitals, temperature was afebrile. Pulse rate, 88 beats per minute. Respiratory rate, 16 breaths per minute. Blood pressure, 140 by 100 mercury, millimeters of mercury. Systemic examination, CVS, S1, S2 heard, no added sounds heard. Respiratory system, normal vesicular breath sounds heard bilaterally. Per abdomen, soft, non-tender. Local ocular examination, head in midline position. Face is asymmetrical, drooping of left upper eyelid noted, and down and out position of the eye is also noted. No abnormal head posture noted. Hirschberg corneal reflex test, 45 degrees of left exotropia was seen. This was performed while retracting her left upper eyelid. Forehead normal, wrinkles are present. Examination of the right eye. Unaided visual acuity was 612 with pinhole improving to 6.9. Near vision is N12. Best corrected visual acuity with cylindrical correction improving to 6.9 and spherical correction improving to N6 near vision. Color vision 17 by 17. Extraocular movements of right eye full, free, painless in all gazes. Eyebrows at the same level, black and normal. Eyelids, normal. Palpebral facial height of 11 mm, MRD1 of 5 mm, MRD2 of 6 mm, and palpebral fissure width of 24 mm. Rhoplast negative. Eyelashes, upper lid and lower lid eyelashes are normal. Sclera, normal. Conjunctiva, bulbar and limbal conjunctiva showed a fleshy triangular fibrovascular growth present in the interpalpebral area of nasal conjunctiva, crossing the limbus and encroaching the cornea about 2 mm, suggestive of pterygium. Palpebral and...
Sir, with your permission, I want to one suggestion.
Yes,
Doctor,
sir. Please go ahead.
Doctor, you must tell the abnormal eye first.
Okay, sir.
Then
Okay,
go
sir.
for normal eye.
Yes, sir.
Because you are wasting the time.
Yes, sir. Examination of the left eye. Unaided visual acuity is 612 partial with pinhole improving to 6.9. Near vision N12. Best corrected visual acuity with cylindrical correction improving to 6.9 and near vision correction N6. Color vision is 17 by 17. Extraocular movements. There was restriction of superior rectus So medial rectus and inferior rectus. And in version movements, there was a restriction of dextro elevation, dextroversion, dextro depression, levo elevation, and levo depression. Levo version was within normal limits. Eyebrows were normal.
Can you
black
explain that image? Just that image,
Yes, ma'am.
extraocular.
Yes,
Tell
ma'am.
what movements are restricted there.
Yes, ma'am. In the left eye, the dextro elevation, dextroversion, dextro depression were decreased. Elevation and depression were also decreased, and levo elevation and levo depression was decreased. Levo version was within normal limits.
Okay.
Eyelids, palpebral fissure height of 0 mm. MRD1 is minus 5 mm. MRD2 is 5 mm. Palpebral fissure width of 24 mm was noted. Rhoplast negative. Eyelashes normal.
Is it the
Sclera normal.
palpebral fissure width you want to measure or the height?
Height, in this case, height is more important, ma'am, but yes, ma'am.
So why do you want to look for the palpebral fissure width?
To see if there's any I'm not sure, ma'am, exactly.
Okay. So that is only
exam-
seen for congenital cases, no? For if there is any blepharophimosis like that, not for a old woman.
Okay, ma'am.
Okay.
Yes, ma'am.
You have
Yes.
to see the height.
Yes, ma'am.
Okay.
Bulbar conjunctiva showed a fleshy triangular fibrovascular growth in the interpalpebral area of the nasal conjunctiva, crossing the limbus and encroaching 2 mm onto the cornea, suggestive of pterygium. Palpebral and pharyngeal conjunctiva were normal. Cornea, normal in size, shape, surface, transparent, and sensations intact in all 5 quadrants. Anterior chamber, normal depth, Van Herrick's grade 4 was noted, and no abnormal content seen. Iris, normal in color and pattern. Pupil, 3 mm, single, round in shape, central in position. Pupillary margin, normal. And reacting well were direct reflex, indirect reflex, and near reflex. Lens, shimmering reflex.
Wait near the pupil. What is the importance of checking about the pupil? Now you are telling me pupil is normal.
Yes, ma'am.
So can you tell any other if what happens when the pupil is dilated or if it is very small? In your case, there is already a ptosis, and then if there is a very small pupil, what is your inference?
Nuclear lesions in third cranial nerve palsies.
What is it? Can you tell one?
Aneurysms, demyelinating disorder.
A ptosis with a very small pupil, meiotic pupil.
Horner's syndrome.
Yes, Horner's. And if the pupil is dilated,
infranuclear lesions in the third cranial nerve.
So what are those? What is the cause? If the pupil is dilated, now what will be the etiology?
The sphincter pupillae has lost its supply. So it can be any damage to the basilar part of the third cranial nerve due to any vascular lesions such as aneurysms, vascular compressive lesions, or microvascular ischemic changes due to hypertension or diabetes.
No, in hypertension and diabetic pupil is not involved.
No, yes.
Only pupil is dilated when there is what you are telling is a
vascular compressive lesions.
So one is a medical cause and another is a surgical cause.
Yes.
So can you tell what is the surgical? You are telling aneurysm. What kind of aneurysm is it?
Berry aneurysms associated with posterior cerebral artery.
So why there is pupil dilatation when there is an aneurysm?
The pupillomotor fibers are present in the superficial part of the third cranial nerve passing through the basilar area. And these are usually easily compressed in aneurysms or tumors.
Okay, so pupil is not involved means what is the etiology there?
Because of microvascular ischemic changes due to hypertension, hyperlipidemia, or diabetic.
Okay. So any other causes for normal pupil with a case of ptosis? So sometimes there is a unilateral, bilateral ptosis, but pupil is normal. What is that case? Most common cause?
Double elevator palsy.
So there is, you are asking about diurnal variation. Why do you ask about
Myasthenia gravis.
so what happens to the pupil in myasthenia?
The pupil remains uninvolved,
Normal.
but with progression through the day, there is progressive ptosis in the patient.
So ptosis, and then pupil, if it is a small pupil, Horner syndrome,
Yes.
dilated pupil, it is a surgical cause, and then normal is a medical cause. Okay, and also myasthenia.
Yes.
Okay.
Yes.
Doctor, what do you mean by double elevator palsy?
When both levator palpebral superioris are affected,
Both levator LPS are affected, then it is called double elevator palsy.
along with superior rectus muscle.
Huh? No. Inferior
I'm not
oblique and
sure,
superior
sir.
rectus.
I'm not sure, sir. I'll read
Inferior
about
oblique and superior rectus.
Okay.
Okay. Hey, you are telling the pupillary reflex. Can you trace the pupillary pathway, reflex sphincter pupillary pathway?
From the afferent fibers start from the retina to the optic nerve. The nasal fibers decussate, and the temporal fibers remain the same pathway. These eventually lead to the pretectal nucleus through the optic tract.
Optic tract next.
What is the nucleus?
Ma'am?
What is the nucleus from which the pupillary margins are coming? Pupillary fibers. What is the name of that nucleus?
From the Edinger-Westphal nucleus.
Yes, that you have to tell. Edinger-Westphal nucleus.
Okay.
And then?
Oh, I was starting from afferent. I'll start again, ma'am. From the Edinger-Westphal nucleus, along with the, they form the parasympathetic preganglionic pupillomotor fibers, which travel along the third cranial nerve, reach the, and through the superior orbital fissure. Once passing through the superior orbital fissure, they divide into inferior and superior divisions.
What is what is the base for the indirect light reflex?
Because of the international fibers present between the Edinger-Westphal nucleus and pretectal nucleus.
They go to the opposite side.
Yes, ma'am.
That you have to tell about the international fibers.
Yes, ma'am.
Okay. From the pretectal nucleus, then to the
along the course of the third oculomotor nerve, they reach the superior orbital fissure, where it divides into inferior division and superior division. The inferior division gives supplies the inferior oblique, and the inferior oblique vessel nerve relays at the ciliary ganglion, and through the ciliary ganglion, short ciliary nerve supply the sphincter pupillae, which leads to constriction of the pupil.
So examination of pupil is very important in your case. Okay.
Yes.
Good. Okay. Continue.
Lens, shimmering reflex scene, pseudophakia, posterior chambal scene. Fundus examination with slit lamp with 90D convex lens. Distant direct ophthalmoscope, red glow scene. Media are clear. Optic disc of normal size, vertically oval in shape, normal color with well-defined margins, with a cup disc ratio of 0.2:1, and a healthy neuroretinal limb is seen. Peripapillary atrophy is noted. Vessels arising from the center of the disc with dichotomous branching, AV ratio of 2:3, and normal. Vessels are normal. Macula FR foveal reflex is dull, and background retina normal. CNS examination, olfactory nerve, cranial nerve, sense of smell intact bilaterally, optic nerve, best corrected visual acuity is 6/9, color vision normal in both eyes, pupillary reflexes, direct reflex, indirect reflex, and near reflex are normal. Right eye confrontation normal, same as the examiner. Left eye confrontation could not be assessed.
Anything you want to see in the cornea? In the examination of cornea?
Sensations, ma'am.
Did you mention the corneal sensations there?
Yes, ma'am.
Okay. So why do you want to check for the other nerves, cranial nerves. Why it is important for us to look at all the cranial nerves?
It can be associated with other nerve involvements such as syndromes.
So tell some conditions in which there is a multiple cranial nerve palsy.
In cases of intracavernous part, when the third cranial nerve along with the fourth and the fifth cranial nerve, the
Yes.
first division and second division are involved,
Okay.
and sixth cranial nerve can also be involved.
What is the name of that condition?
Keratocavernous syndrome.
Okay. Any other causes
Any other?
for multiple cranial nerve palsies?
Orbital apex syndrome.
So how to differentiate that condition from your condition?
Keratocavernous fistulas, they can have proptosis with
No. How will you diagnose an orbital apex syndrome? What will be the visual acuity?
decreased. Visual acuity is lost. Yes.
If there is no vision.
Yes.
Okay.
Yes.
Any other area where there is a multiple cranial nerve palsy? You told cavernous sinus.
Yes, ma'am.
Orbital apex. Any other causes?
In the nuclear pathways affecting the fourth cranial nerve that is present distally and sixth cranial nerve.
Superior orbital fissure.
Okay. Yes.
So you should learn about these things when we ask about the multiple cranial nerve palsies.
Yes.
Okay, go to your CNS examination. How will you check for a corneal reflex?
A cotton wig can be used and the patient is seated comfortably. The patient is asked to look straight ahead and the wig can be brought from lateral to the patient, not obstructing his view, and can be checked in 5 segments: the superior, inferior, temporal, and nasal and central.
Why do you want to check in all the segments? What is the importance of checking in all those 5 segments? Now you told
The
you
nasociliary
the
nerves.
center. So if what will happen if that patient is from the center, you are bringing the cotton wick, what will he will do?
He'll obviously blink with his reflexes.
So what is that called as?
The facial orbicularis oculi reflex with the facial nerve.
Menes reflex.
Yes, ma'am.
Okay. So what are the afferent and efferent for the corneal reflex?
The afferent is through the trigeminal nerve. The afferent is through the facial nerve, whereas the efferent is through the trigeminal nerve. The efferent follows the nasociliary nerves into the mesencephalic
What is the
nucleus.
nerve that is supplying the cornea?
The first division of the trigeminal nerve.
So what is that name of that first division?
Nasociliary nerves.
Is it the ophthalmic division?
Ophthalmic division, nasociliary nerves. Yes, ma'am.
And what is the efferent?
The facial nerve, which supplies
Which
the
supplies the yellow. Facial nerve supplies the why they are
orbicularis
blinking?
oculi muscle, which leads to blinking.
Yes. So you are testing the trigeminal nerve, facial nerve.
Yes.
Okay. And how will you test for the fourth nerve?
The trochlear nerve can be, we will mark a vessel at 12 o'clock position of the examining eye, and we will ask the patient to look downwards. There will be intorsion of the inward movement of the marked vessel, which indicates that the action is normal.
So what will be the symptom when there is a fourth nerve palsy? Are there any complaints from the patients?
Tilted appearance of objects.
When they will have difficulty while climbing down the steps.
Yes. Okay. Yes.
Okay, so that is important.
Yes.
Okay. Continue.
Trochlear nerve and abducent nerve, normal extraocular movements noted, that is intorsion and abduction. Trigeminal nerve, facial sensations intact in all
All
three.
the nerves are normal.
Yes, ma'am.
Okay, now you can skip that part.
Yes, ma'am. Diplopia cover test was done. Left eye tropia was noted. Cover uncover test also indicated left eye tropia. Alternate cover test showed left deviation of 45.
Doctor, 1 minute. Cover test for what?
To ruling out tropia, sir.
Cover uncover test?
To identify if there's any phoria, sir.
Then the cover uncover test left out tropia is mentioned.
Yes, sir.
Alternative cover test?
To calculate the maximum amount of deviation noted.
Okay, carry on. Carry on.
Force reduction test negative in left eye, indicating paralytic restriction.
What is this force reduction test? How will you do it?
Under topical anesthesia, we will use a tooth forceps and we will ask the patient to look towards the deviated muscle, and we will hold limbus 180 degrees opposite to the muscle that we are evaluating, and we will move the muzzle towards the direction of the deviation to see if there's any restriction along the movement. If there's any restriction, it indicates that there is mechanical restriction due to orbital fractures. And if the movement is free, it indicates that it is paralytic causes of restriction.
Do you think that restriction always indicates orbital fracture?
Sir?
Do you think that restriction always indicates orbital fracture?
Other space occupying orbital lesions also can.
Without space occupying lesions, there may be sometimes there may be restriction.
In cases of prolonged paralytic squint,
what happened when medial rectus is fibrosed?
There can be contracture of the muscles, and
then there will be restriction, no?
Yes, sir. Yes, sir. False negative.
Okay.
Can you tell some complications while doing this force reduction test?
Cornea can be aberrated during force reduction test.
Any serious complications? You are holding the muscles.
Disengagement of the muscle at the insertion site.
No. What is oculocardiac reflex?
There can be bradycardia with.
So whenever you are holding the muscles, you should keep in mind that there can be oculocardiac. So sometimes when you are called to the casualty, when there is some fractures, you want to do it. First, you have to see whether the patient is stable or not.
Yes.
Okay, and then you have to perform this test. Is very painful for the patient, especially when there is a fracture. Yes. You have to keep in mind about the oculocardiac reflex. Yes. Then what is a force generation test?
We will look for the amount of force that is generated in the muzzle to identify if the muzzle can be operated or not for squint surgery.
No, we are comparing the tone of the muzzle from this side to that side.
Yes.
Okay.
Okay.
Carry on.
Summary. A 67-year-old patient, Ravanamma, with history of type 2 diabetes mellitus since 6 years, systemic hypertension since 2 years, on regular medication, has come with complaints of drooping of left upper eyelid associated with since 4 days. On examination, complete ptosis is seen with limitation of all extraocular movements except for abduction and intorsion in the left eye, and grade 2 nasal pterygium in both eyes with normal direct and indirect pupillary reflex. Left eye showed negative force reduction test. Provisional diagnosis: right eye grade 2 nasal pterygium and pseudophakia. Left eye grade 2 nasal pterygium, pseudophakia with isolated pupil sparing, complete third cranial nerve palsy due to microvascular ischemic causes with probable etiology of uncontrolled diabetes and hypertension.
Can you refine the diagnosis? Left eye?
Isolated pupil sparing, complete third cranial nerve palsy due to microvascular ischemic causes.
You need to tell us.
How do you know it is due to microvascular ischemic cause?
Sir, she has a blood glucose level of 364 mg per deciliter, and her recording while examination of blood pressure was 140/100, even with
I don't
medication.
think you need to mention about that in the diagnosis. You don't have to mention about that in the diagnosis.
Yes, sir.
That is the pathogenesis.
Yeah, that's totally different. It's not in the diagnosis.
Okay. Yes.
Diagnosis is something that you see directly in
Yes,
the
sir.
patient.
People is pairing complete third nerve palsy with pseudopecia with nasal pterygium grade 2.
That's enough.
That is
Okay,
enough.
sir.
So
Yes, sir.
it is only external ophthalmoplegia.
Yes, sir. Yes, ma'am.
So what are the other tests you want to do in a ptosis?
LPS overaction, Bell's phenomenon.
Overaction.
Overaction, or you want to see for the LPS function?
LPS function.
So what is that test? Name of the test? How will you do it?
We will occlude the frontalis action with the thumb, and we will ask the patient to look down, and then we'll ask the patient to look up, and we'll calculate the distance between the difference between the palpebral fissure height.
What is the use of measuring the function of the LPS? Why is it important to see how the function is? Do you want to decide on what type of surgery you want to do?
Frontalis sling operation can be decided if the action of frontalis muscle is good or fair.
Frontalis muscle?
It's not the frontalis muscle. Frontalis sling.
Sling operation, yes.
Depending upon the LPS section, how will you grade that LPS section?
It's divided into good, fair, mild, and poor. The normal is 15 mm, sir. 11 to 14 mm is considered fair. Less than 11 mm, it is divided into poor and.
When it is less than 4 is poor.
Less than 4 is poor.
Poor. You in such cases, you go for sling.
Yes.
Okay. And then what is an ice pack test?
So we will see if there's any improvement in myasthenia gravis patients. So with ice pack application for 1 to 5 minutes, there will be improvement in the palpebral fissure height in myasthenia gravis patients.
So even that also you have to mention in your examination.
Yes,
are there any drugs which are used in the diagnosis of your ptosis?
Edrophonium and neost.
Any drops you can put and then you can want to measure? Okay, you have to learn about the evaluation of ptosis. Okay,
Yes.
You just told MRD 1, 2, and then you have to mention all the investigations.
Yes. Yes.
Okay, so now what will you do for this case?
In this case, we will strictly control her diabetes and hypertension, and we will monitor the case every 2 weeks. And we will also
do any neurological imaging in this case
of
or
MRI.
not?
Yes, ma'am. MRI.
The indication for MRI?
In this patient, there is uncontrolled diabetes and hypertension, ptosis, and also.
No.
What is the important indication that it is emergency?
Why do you want to do an MRI
above
for
the
this?
age of 50 years, sir?
No,
this is you are telling it is a diabetic. When do you want to do an MRI? MRI
angio.
In younger patients of under 50 years of age with pupil involvement.
Yes. This patient does not need, you can wait.
Yes.
Okay, when will the third now, how much time it will take to recover?
6 to 12 weeks. 6 to 12 weeks for improvement.
Okay.
Is it a nuclear or a peripheral level? This one.
Sir?
Is it nuclear level or peripheral?
Infranuclear level, sir.
How can you differentiate nuclear level?
In nuclear area, if the entire nucleus is involved, there will be bilateral ptosis.
Entire nucleus means how many paired are there? How many unpaired are there?
Sir, 5 unpaired
What are they?
sir, it's divided, motor nucleus is divided into main motor and accessory nucleus, sir. In main motor, there are paired nuclei for inferior rectus, superior rectus, inferior oblique, medial rectus, and
What is the characteristic feature of superior rectus nerve supply?
it supplies the contralateral muscle, sir. Contralateral eyes, superior rectus.
Yes.
Yes,
Then
correct.
nuclear level, then how will they assess the nuclear level now?
If both bilateral ptosis can be present because of unpaired LPS muscle,
Okay.
unpaired LPS nucleus.
What is the action of other eye elevation? In the right eye elevation, is there any deficiency in this case?
No, sir. No, there's no restriction in the other eye, sir.
Then, if it is a nuclear level, there is a complete terminal palsy, unilateral terminal palsy, other eye elevation defect is present. No, bilateral ptosis.
Yes.
Then, can you tell the Darab's rules?
Sir?
Darab's rules?
Sir, can you repeat it one
Not
more?
clear.
Darab's rules to the differentiate nuclear and below nucleus.
Based upon the pupillary involvement and I'm not sure, sir.
Okay. Can it be at the level of the this one fascicular portion?
Yes, yeah, superior fascicular portion.
Now, what are the syndromes? If it is a fascicular, sir is asking fascicular.
Yes. In the fascicular portion, if the red nucleus is involved, the Weber syndrome is seen. It is
No,
associated.
red nucleus is Benedict syndrome.
Yes, ma'am.
Benedict syndrome.
Yes, ma'am. Yes, ma'am. In the fascicular part, Weber syndrome and North-Nagel syndromes are seen. In Weber syndrome, it is associated with third cranial nerve palsy and contralateral hemiplegia, sir. And North-Nagel syndrome, there can be third cranial nerve palsy and contralateral ataxia. In Benedict syndrome, the red nucleus is involved and it is associated with contralateral tremors or involuntary movements, sir. Claude syndrome is a combination of Benedict's and North-Nagel syndrome, where the red nucleus and the cerebral peduncular area is also involved. It is associated with cerebral ipsilateral third cranial nerve palsy, contralateral ataxia, and hemiplegia, sir.
Okay.
Second case time out.
Yeah, this time for the second case.
Okay.
Yes, very good presentation, Khyati.
Thank you. Thank you, ma'am.
Good.
You candidate pass cheddama.
Pass, sir. She did well.
Thank you, ma'am.
Good presentation, Dr. Khyati. So let us move on to the second case. Dr. Pranav, are you ready? Okay, you already started your presentation.
Yes, sir.
Right. Make the screen bigger. Okay, good. Go ahead. Go ahead with your presentation, Dr. Pranav.
Good evening, sir. I'm Dr. Pranav, second year PG of the Sudarshini Eye Hospital. I'm presenting today a 37-year-old male patient, businessman by occupation, who came with the chief complaints of defective vision for distance and near for both the eyes since 3 days, appearance of black spot in front of the left eye since 3 days. History of present illness.
Doctor, what is the importance of occupation in ophthalmology?
Sir?
What is the importance of occupation in ophthalmology?
Occupation in ophthalmology, sir. Occupation we can determine how will be the quality of the ocular surface anterior segment based on the occupation, sir. For example, if the patient is a farmer, sir, he will be working in a dusty environment. Exposure to the UV radiations will be there. So
more than that, farmers are exposed to more trauma. Because they work and arc welders are exposed to injury, the burns, corneal and
yes,
this one. No. Fishermen, those who go and see the UV rays are reflected and affects the eyes. No, photoretinitis, photoophthalmitis.
Yes.
No,
Yes, sir.
That is the importance of our question. Okay.
Trauma. Yes, sir.
And now present burning problem is computer work syndrome.
Computer vision syndrome, sir. Yes, sir.
Okay.
Yes, sir.
Okay, carry on.
Yes. History of present illness. Patient was apparently all right 3 days back when he developed defective vision for distance and near, which was gradual in onset. Patient complained of seeing a spider web-like in front of the left eye, which was moving with eye movements, which was painless and sudden in onset.
Just small correction. Whenever you are telling, even the previous girl also told, like apparently all right is not. Apparently asymptomatic is the correct word. You keep that word, one thing. And
okay, sir.
Second thing is like whenever you are saying the defective vision, was it painful or painless?
Painless, okay, sir. Painless visions, defective vision, painless loss of vision.
Yeah, painless loss of vision.
Yes, sir.
Sudden onset, painless loss of vision. What are your differentials in mind by this time?
Painless loss of vision, sir. First, with this presenting complaints, we can think of, sir, first is uveitis. And then
Uveitis
second is,
painless?
Uveitis is painful.
sorry, sir, painless. Okay, painless. So we are asking, sir, glaucoma can be there. Detachment
What type of
can be
glaucoma?
there.
What type of glaucoma?
Primary open angle closure glaucoma, sir. And PVD can be there. And retinal detachment, sir. This much is coming to my mind, sir.
Okay,
You start from the cornea and then go back to the causes which are painless, corneal conditions, painless, sudden loss of vision.
First, on the cornea, sir, dystrophies can be there, sir. Degenerations or dystrophies, corneal, then ulcers, sir. Then
Ulcers are painful. You can
Ulcer is
tell a corneal opacity.
opacity.
So you have to
is-
divide into painless and painful. Then learn about the causes.
Okay, ma'am.
So what are the differentials? Whenever you are putting the questions, next questions, you should have some differentials in mind.
Yes,
So what
sir.
are these?
There is no history of flashes. There is no history of pain, redness, watering, and photophobia. There is no history of headache, no history of trauma, no history of constipation or chronic cough.
So what
And
are you asked
patient
for headache?
Sir? Sorry, sir, I did not hear you, sir.
Headache, what for you asked? What is the differential you in your mind for headache in this case?
Headache, sir, I was just ruling out hypertension can be there, migraine can be there, sir. Mainly hypertension and migraine. This was the two main things I wanted to rule.
Yeah. Any other cause in the older age group which you want to specifically sudden painless loss of vision in the older age group? Maybe 60s, 50s, associated with headache and jaw claudication. Arthritic ischemic optic neuropathy, non-arthritic and anterior ischemic optic neuropathy. Okay.
Yeah.
So whenever you are putting the question, that should carry a meaning. Huh?
Okay, sir.
Okay. Ask it. Next question is the trauma. What is the differentials in because of the trauma and painless sudden loss of vision?
Sir, I'm unable to hear you, sir.
Painless sudden loss, whatever question you are asking should carry a meaningful response. Okay. So you ask it, no history of trauma. So what is that? Which trauma causes can cause sudden painless loss of vision?
Sir, I'm not able to hear you, sir.
No, what is the cause for a trauma? You are asking in trauma.
Why do you ask for trauma?
You are telling it is a painless loss of vision, no?
Yes, sir.
What is
Sir,
the cause? Sudden loss of vision in a trauma.
PVD can be there, ma'am.
That does not cause sudden loss of vision.
Detachment, retinal detachment can
And
due to trauma.
sudden loss of vision.
Vitreous hemorrhage, ma'am.
Good.
Yes.
Good. Continue.
Past history, no similar complaints.
Can
in
you
the
tell
past.
the positive findings?
Yes, ma'am. Positive findings, okay.
Yes.
Okay, ma'am, I will go by the
history, positive
In the
findings.
history, anything relevant history is there? Are they
no, ma'am.
diabetic?
Diabetes, ma'am. Systemic history of diabetes since 15 years, ma'am. Patient is on voglibos, glimepiride, and metformin. And patient is also using sitagliptin and dapagliflozin. Since 15 years, he is diabetic.
Diabetes is systemic history.
Sorry, sir.
Diabetes comes under systemic history.
Sir, past history or
Past history. Why it is past?
It is
One of the, if you treat it, it is cured. Again, it develops.
no.
Then how can it be past? It is comes into
Present.
personal history. Diabetes and diabetes all comes under personal history. Once you diagnose it as diabetes, means it is present for lifelong.
Sure.
It will not come past. Okay. Tuberculosis, leprosy, Hansen, Gansen, all comes under past. Okay,
sir.
carry on.
General examination. Patient is conscious, cooperative, and oriented, moderately built and well nourished.
Okay, all within normal limits.
okay.
Hmm.
Yes. Next.
Go with the positive findings.
Sir, directly I will discuss about the posterior segment, sir.
Okay.
Any positive findings you want to see in the anterior segment before going to the fundus? Anterior segment findings. Anything in particular you want to see in your case? Something in the iris?
Neovascularization, ma'am.
Yes. Why did you do gonioscopy?
Ma'am, to rule out neovascular glaucoma, ma'am.
Okay.
Yes, ma'am.
Okay. So go to the fundus examination.
Yes, ma'am. Fundus examination, red glow was seen with the direct distance ophthalmoscope for both the eyes, it was present. And disc was examined with plus 90-day Vogue lens, which showed normal size and florid NVDs in right eye. Shape was normal, color was pink, and margins were very
What is this florid NVD means? What? You have to describe the finding. What did you see on the disc?
Fine filiform vessels arising from the disc, covering more than one half of the total disc, which was suggestive of florid NVDs.
How will you differentiate these vessels from the normal vessels?
Ma'am, first is the caliber of the vessels, ma'am. Florid will be very fine filiform vessels, and I would like to do FA also, ma'am. FA will show hyperfluorescence leakage will be there, and normal vessels won't leak, ma'am.
While seeing the fundus, how will you differentiate normal vessels from a neovascularization?
Normal vessels will be branching dichotomously, ma'am.
Yes.
New vessels will be crossing one vessel to the another vessel, ma'am. They will not. Yes.
How many vessels are there on the optic disc?
2 arteries and 2 veins.
Only 2. Is there any importance for counting the blood vessels on the disc?
Of vessels on the disc.
What is Kestenbaum's?
Index.
Index, okay. Yes, ma'am.
What is it?
What is it?
Sir, I'll read about it.
Okay, okay. Continue. Now you have seen new vessels on the disc.
Yes, ma'am. I'm discussing about the right arm. On the posterior pole, there are microaneurysms and exudates surrounding the macula. And blood vessels, AV ratio was 2:4 with a mild venous engorgement. And neovascularization and erythemas were noted in the inferior arcade. And macula, there was edema present and foveal reflex was absent. This is the fundus drawing of the right eye. And coming to the left eye, red globe was present. Disc was of normal size.
Macular edema, still more characterize it like whether it, how far it is from the fovea and all these things with a 90D. Can you make out?
NV is, sir.
From the fovea and all. Because you told you were examined with 90D.
Yes,
Just
sir.
macular edema in the is like macula is a very big area.
Yes,
So
sir.
in relation to fovea, I have to tell where is the macular edema in relation to fovea.
Sir, 2 disc diameters from the disc fovea is present.
Define CSMA.
No, you are telling macular edema. How did you diagnose that macular edema?
Ma'am, clinically significant macular edema was there, ma'am.
What findings did you see there?
Ma'am, exudates were present in the central area, along with the adjacent retinal thickening was present, ma'am. So it was suggestive of clinically significant macular edema, ma'am.
So what is the measurement for clinically significant macular edema? The criteria, they were told some microns distance from the fovea.
Yes, sir. Hard exudates greater than 500 microns with adjacent retinal thickenings. This is suggestive of clinically significant macular edema.
There are 3 criteria.
Yes, ma'am. First is retinal thickening greater than 500 microns in the around the 500 microns area of the fovea. Second is hard exudates along with adjacent retinal thickening around the 500 microns from the fovea. And third is an area of retinal thickening greater than 1500 microns, any part of which comes under the central 500
area of thickening about 1 disc diameter, no? That comes into the
any part of which comes in the central 500 microns.
Okay. So how will you diagnose an IRMA? You told you have seen some IRMAs there.
Yes, ma'am.
How did you diagnose IRMA?
Clinically, if I diagnosed them by there were shunt vessels, ma'am, which were joining the arterioles with the venules, ma'am, and they usually do not cross the blood vessels, ma'am. That is the way I diagnosed it, ma'am.
Okay. Left eye, fundus.
Sorry, ma'am.
Fundus findings in the left eye.
Yes, okay. Left eye showed size of the disc was normal, and NVDs were proliferating into the vitreous cavity. Shape of the disc was round, pink, and well defined. Cup disc ratio was 0.3:1. NRR was hyperemic. Peripapillary area was normal, and at the posterior pole, microaneurysms and exudates surrounding the macula was seen. And blood vessels, they showed a AV ratio of 2:4 with venous engorgement. And
microaneurysms and exudates. What type of exudates are there?
Hard exudates, ma'am.
How did you differentiate these hard exudates from drusense?
Hard exudates will be waxy yellowish lesions with distinct borders, ma'am, and usually arranged in clumps, and they will be larger in size, whereas drusense will be small pinpoint lesions, ma'am, and they will be much deeper in the retinal layers.
Continue.
Yes, ma'am. Blood vessels, neovascularization and IRMAs were noted in the superior and the inferior arcades. Again, macular edema was present and foveal reflex was absent. This is the fundus drawing of the left eye, and in the inferior arcade, we could see a streak of blood vessels, streak of blood, which was of which the underlying blood vessels were not visible, suggestive of subhyaloid hemorrhage.
What is the name of this chart?
Sorry, sir.
You have drawn a drawing on one chart. Now, what is this chart is named?
Amsler Du Bois chart, sir.
Yeah. Have you done the indirect? Or
Sir,
just
you are not audible, sir.
have you
Sorry?
done the indirect or 90-day examination?
Sari is asking, have you done the indirect ophthalmoscope or not?
Yes, sir, I have done so.
So this is your indirect ophthalmoscope findings, or 90-day findings you have drawn here.
This is my indirect ophthalmoscope findings, sir.
Both.
Yes.
I think.
So what is
I
the
think
image
it's a mixture of both.
characteristics you see? You define whenever you are using the indirect ophthalmoscope, what is the image formed? What is the principle of indirect ophthalmoscope?
Sir, image will be real and inverted only, sir. When we are seeing the posterior pole and the disc, sir. And when we are seeing the inferior quadrant, we are seeing the inferior part of the retina, sir. But there the images will be reversed, sir, and laterally reversed.
Okay.
What is the basic principle of indirect ophthalmoscope?
Sir.
What is the basic principle of indirect ophthalmoscope?
Sir, I'm not able to recollect now, sir.
Okay. Then what is the diagnosis?
So in summary, a 37-year-old male came with the complaints of defective vision for distance and gulf of 3 days duration with a known history of diabetes since 15 years, whose fundus examination shows neovascularization of the disc and neovascularization elsewhere, along with associated exudates and macular edema of both the eyes. So my provisional diagnosis was both eyes high risk proliferative diabetic retinopathy with clinically significant macular edema and both eyes myopia.
Doctor, you told this patient is 15 years diabetic. Did he had any eye examination before?
No, sir, he has not done any eye examination, sir. He has come first time to our hospital.
Ideally, what is the recommendations for a diabetic patient when he is detected with diabetes? After how many days he has to undergo eye screening?
Sir, if he is a type 2 diabetic, he has to go for diabetes screening as soon as he is detected for diabetes. And if he is a type 1 diabetic, after 5 years of diagnosis, he has to start going for a screening of diabetic retinopathy.
So he is 37 years old. You told like 37 years old. Age of onset of diabetes is like 22 years. That means he is like 15 years diabetic.
Yes, sir.
So age of onset is around 22 years. Correct?
Yes, sir.
And then what are the features of a high risk PDR?
Okay, so high risk PDR, ma'am, there will be NV days more than half disc diameter of the disc. There will be NVD associated with vitreous hemorrhage and NVE is associated with pre-ret hemorrhage, ma'am.
According to which classification?
Sir?
According to which classification?
Sir, ETDRS classification.
What is that classification?
ETDRS.
What is that classification?
ETDRS.
Early treatment of diabetic retinopathy.
Okay, what are the various stages are there now?
Explain the ETDRS. What is mild, moderate, severe? That is the question.
Okay. Mild NPDR is few microaneurysms seen. Moderate NPDR, few microaneurysms along with hemorrhages are seen, and moderate to severe is hemorrhages in 1 to 3 quadrants plus in any one quadrant there should be an
4 to 1 rule. That is 1 2 3, not 1 2 3. The 4 to 1 rule is there, no?
Sir, see, it comes under severe NPDR, sir. 4 to 1. And in moderate, there is 1 to 3 quadrants hemorrhages, and any 1 quadrant venous bleeding. And in severe NPDR, 4 to 1 rule, sir. 4 quadrants there will be hemorrhages greater than 20. 2 quadrants there will be venous changes, and in 1 quadrant there will be erymas.
What are the venous changes?
Sorry, ma'am.
What are the venous changes which occurs in a diabetic retinopathy?
Venous looping, bleeding, segmentations can be there, ma'am. Circulations, bleedings can be there. And NVEs can be there, ma'am.
Now, what investigation you want to do for your case now?
Ma'am, first, I would like to do, I will like to investigate the general condition of the patient first, ma'am. I will check for lipids, I will check for hemoglobin, then I will check for creat.
Why do you want to see the hemoglobin? What is the importance of seeing hemoglobin?
Ma'am, anemic retinopathy, I want to rule out, ma'am. And first, this is first, and anemia can worsen diabetic retinopathy, ma'am.
What are the other conditions which can worsen diabetic retinopathy?
Diabetic nephropathy, ma'am. First, obstructive sleep apnea, then hyperlipidemia, and hyper.
What are the conditions which can delay a diabetic retinopathy?
Conditions delaying diabetic retinopathy. Sure, ma'am.
It is there in your diagnosis.
Otherwise, like asymmetric DR presentation, in which conditions you see?
Sir, can you repeat, sir?
Asymmetric diabetic retinopathy. Which condition do you see?
Sir, ocular ischemic syndrome. We can see asymmetric diabetic retinopathy, sir, and
in pathology.
Ocular ischemic syndrome.
Any other pathology that can delay the progression ocular condition?
Any degenerative conditions, you know, which can cause night blindness?
You already told the answer also.
Madam also given clue.
He is a little bit confused. Okay. So go ahead. Now, what ocular investigations will you do for this case?
Ocular examination. First, I would like to do OCT, ma'am, and fundus photograph. OCT.
Why do you want to do OCT?
I'm first OCT for I want to check if the macular center is involved or not involved. It will help me in the treatment part, ma'am. And
what are the different types of what is the OCT classification? Center involved, non-center. What are the different types of diabetic macular edema?
Different types of diabetic macular edema are, ma'am, spongiform, cystoid, cystic with subretinal fluid, and taut posterior hyaloid.
Is there any detachment?
Vitromacular traction.
Not traction. I'm asking about the macular edema. With neurosensory detachment.
Detachment. Okay, yes, ma'am. With neurosensory detachment.
So how it is going to help for your treatment? You are doing an OCT.
If it is a center involving diabetic macular edema, we will go first for the anti-VEGF injections, ma'am. And if it is a non-center involving macular edema, we will go for first lasers, focal laser or grid laser.
How does this laser help in the treatment of a macular edema?
Ma'am, a laser first, it can be diffuse leak or focal leak, ma'am. If there is a focal leak, we can do focal laser to that particular bleeding microaneurysm, ma'am. And if it is a diffuse leak, we can do scatter photocoagulation, and this laser will convert hypoxic retina to anoxic retina, ma'am. and also
that does not
this will
help with your macular edema. That hypoxic anoxic is for the pan-retinal photocoagulation. So we are asking about macular edema. You wanted to do a laser in macular edema. How does it help?
at that particular point we can
Yes. A focal leak is there. You can. Okay. Any other? Does it improve any pump mechanisms for the retinal pigment? You have to read about the pathophysiology.
Okay, ma'am.
It will activate the RPE so that the
RPE
pump
is
mechanisms.
The migraine cells, no.
Okay.
Okay.
What is various pathological mechanism, pathophysiological mechanism of diabetic retinopathy?
So first is hyperglycemia. This will open up many pathways. First is aldose reductase, diacylglycerol, and hyper AGE is advanced glycation end products. All these pathways.
What is the end
will
product?
lead
Finally, what is the end product?
protein kinase C, sir.
See, yeah.
Protein kinase C will damage the capillary endothelial walls, and this will lead to
Is it not sorbitol?
sorbitol pathway also, sir.
Okay.
Accumulation of the sorbitol.
Sorbitol.
That leads to the
What
changes.
happens when sorbitol accumulates in the cell? What happens?
Sir, if there is accumulation of sorbitol, for this reaction for glucose to sorbitol,
Yes, sir. The end product is the sorbitol, no? When hyperglycemia is there, automatically glycolysis stops and all the reductase pathway activated. End product is sorbitol. Sorbitol accumulates in the cell. What happens to the cell when sorbitol accumulates in the cell?
Sir, increase in the hydrostatic pressure will happen, sir.
Okay.
No. What sir is asking is what are that microangiopathy is there, no? What changes are happening in the vessel wall? Those things you have to.
Parasite loss will be there.
What is the earliest histopathological sign you see in diabetic retinopathy?
Sir, can you repeat, sir?
What is the earliest histopathological feature you see in a diabetic retinopathy?
Sir, loss of parasites, sir. Parasite loss.
Parasite loss or death, apoptosis, sir. What is
Thickening of the basement membranes.
Thickening of the basement membranes, parasite loss.
And what are other mechanisms?
Advanced glycation end products is
Okay, glycation, they leave that one. That is completed. Next. Any clotting factors are involved?
Clotting factors.
Yeah.
Not sure.
Platelet stickiness is increased, no? Why?
So that.
What is the role of HbA1c? Now everyone is asking HbA1c, HbA1c.
So chronicity of the disease status.
Okay. What is its role in diabetic retinopathy form development?
So what is the most important risk factor for the development of duration
of the diabetes?
Next is the uncontrolled. First is duration, second is the uncontrolled.
When HbA1c is increased, oxygen carrying capacity with HbA1c is markedly decreased. Okay. All these leads to narrowing of the vessels or blocking of the vessel.
Okay, sir.
Okay.
I will read about it.
Okay. What will you do for your case now?
First, I will like to give first 1 dose of anti-VEGF, ma'am. Then when
is there any role of FFA?
Yes, sir. FFA will help us to detect macular ischemia, capillary non-perfusion areas, and any bleeding microaneurysm, sir.
Sir will elaborate more. Sir Venugopal sir. Hello?
Sure. Hello, sir.
Sir, elaborate more. FFPA, sir.
FFA, in this case
diabetes.
only, it is not needed in this case, sir, actually, because
Okay.
OCT we can do, and NVE is clear cut. So
Yeah.
because FFA is an invasive procedure, we don't do it in this case, actually. But if there is a CSME and if you are suspecting diffuse leakage, then you can do the FFA and mark even to check the nowadays capillary dropouts, you can do the OCT angiography also. So if you want to do the grid laser to the capillary dropout areas, OCT angio I recommend rather than FFA. Now the FFA is having a limited role because when you have a severe NPDR or a PDR doubtful, those cases we are using most of the time FFA.
Okay.
For macular edema per se, nowadays, if you want to see the capillary dropout area, OCTA is taking over the FFA. So invasive, non-invasive procedure.
Okay, sir.
Pranav,
What
stop
are
sharing.
the indications of vitrectomy in your case?
Indications, first would be dense vitreous hemorrhage if we are not able to see, or persistent vitreous hemorrhage, and if there is a macular involving traction, then we should go for vitrectomy.
Doctor, you mentioned myopia. Is there any relation with myopia and diabetes?
Dr. Pranav, stop sharing.
Okay.
And you can continue with your. Yeah. Sir, ask you some question.
Myopia and the diabetic retinopathy.
Not diabetic retinopathy, it's diabetes.
I could not think about it also.
Now, what are the effects of diabetic on the eye? So, in the cornea, for the refractive errors, can the levels of your blood sugar change the refractive error?
Hydration of the lens will be there, ma'am. In
What
diabetes.
type of cataract you will see in diabetes?
Snowflake cataracts or PSC cataract will be the snowflake cataract.
Okay.
And when there will be dehydration of the lens, there will be a hyperopic shift, sir.
There is a definite relation between a refractive error and control of diabetes. Where blood sugar is not controlled, refractive error changes, no?
Yes, sir.
Can you name any important studies in diabetic retinopathy?
Yes, ma'am. First is the DRS study, ma'am. They proved that the PRP laser is effective in PDR. This decreases the severe vision loss, ma'am. This is the DRS study. Then next is ETDRS study, ma'am. ETDRS study assesses the efficacy of PRP laser in diabetic in other diabetes, leaving aside high risk diabetic retinopathy. And then there is DVS study, ma'am, which tells about the significance of the vitrectomy in diabetic retinopathy, ma'am.
What is an ACCORD study?
ACCORD study and field study, ma'am, they tell about the significance of hyperlipidemia in diabetes.
Can you expand what is that ACCORD means?
I don't remember it now.
You have to learn all the landmark studies, okay?
Phenofibrate is to be prescribed, ma'am, if levels are moved.
What is the laser you use here?
Sorry, sir.
Laser.
Which type of laser? Frequency and type of the laser you use for treatment here?
Frequency double NDX, NDX laser.
Tell the laser parameters, no? What is the strength? What is the size of the burn?
200 spot size, 200 microns of spot size, and intensity will also be 200, 250, and power we can adjust according to the grade of the cataract.
What is the range of the power?
Anything ranging from 150 to 350, so we can use.
150 watt kilograms?
No, sir, millijoules.
Yeah, you should tell the units.
Yes.
Now, can you tell any complications for the laser photocoagulation?
Laser photography. Yes, ma'am. Complications will be divided into early and late, ma'am. Early, there will be a sudden contraction of the vessels, which will lead to vitreous hemorrhage. And late complications can be laser blooming can happen, ma'am. The spot size they will coalesce, and later contraction of the uh,
Now, what are the
membranes.
problems patients will have? Any complaints from the patients? That's what I'm asking.
Night sensitive contrast sensitivity will be there, ma'am, and in night vision the patient will experience problem.
Peripheral
will you-
vision, anything?
Peripheral vision and night vision,
Night
restriction
vision,
of the visual fields, constriction. Okay,
Any
how will you
accidental burns of-
how to differentiate
accidental
this
burns of the
laser
COVID?
burns from chorioretinitis?
chorioretinitis, ma'am, lesions will be deeper lesions, and the blood vessels, overlying blood vessels will not be clear. Vitritis will be minimal.
No, old chorioretinitis patches and old laser burns.
Old laser burns will take a color of pigment, and they will become pigmented, ma'am. Black scars will.
So how is the pigmentation in a laser and how is the pigmentation in a chorioretinitis patch?
Not sure.
Healed
So you have to
chorioretinitis
learn.
patches, no? Healed chorioretinitis patch is there.
Chorioretinitis patch, you have to describe it. It is a punched out lesion with a
Pigmented
peripheral
markings, no?
pigmentation.
Peripheral pigmentation, yes.
Center
In
also.
laser, the pigmentation is in the center. They are equal size. All burns are of equal size and
Equal
distributed,
size.
no? The distribution of
Yes,
the burns. So you have to learn the differences. Okay?
Yes, ma'am.
Good presentation. And then better next time if you can put up a fundus picture also, we will see what actual findings are and what your images are. Try to get a fundus picture also.
Do
Okay?
you have a fundus picture
Yes.
with you, Dr. Pranav?
No, sir. No, sir.
You have to put it, okay? In the exam, maybe they won't ask, but for this kind of things, we may correlate.
But in the exam, patient will be there, no, madam?
Yes, sir. That's what. I thought he will show the fundus picture.
Okay.
You told
Right.
yes.
Oh.
Thank you very much. Thank you very much, Dr. Sirisha. Thank you very much, Dr. Venugopal Reddy. And also my
Thank you,
colleague, Dr. Tarakeshwar Rao. It's a very good presentation by both Dr. Khyati and Dr. Pranav. And very extensive discussion by Dr. Sirisha mainly. And thank you, Dr. Venugopal Reddy, also for taking part in this. And I think we'll wrap up today's session. I would like to thank Dr. Danya and Dr. Padma Priya. Both of them are very silent, just watching. They are not participating in the in the discussion.
I've done our participation before, sir. Now we can't participate.
We did not give them much choice, maybe.
Yeah. You
We
particularly you
keep
didn't give
calling
anybody
him
any
for-
choice.
Ball is in your court.
Just the basics only, sir. We are asking only
Yes,
the
yes.
basics.
Very nice
We don't
question.
have to-
Very nice.
I'm very happy about the discussion that has happened, because you have extensively covered each and every question that a postgraduate will face when they go for the exam with a similar case.
Yes.
So this webinar is very useful for all the postgraduates. Even if they are not able to participate now in the webinar, they can still watch this video, which is there in the YouTube. Anytime they can watch this video and then compile all the questions and prepare answers for these questions, so that it will be very useful for them in their exams. I thank the video technologies for coordinating this webinar. And again, we'll be meeting for our next short cases webinar. It will be on next June. I'm not sure about the date. Can anybody help me with the date?
26th, sir.
26th of June. 26th of June, we'll be coming up with the next short cases webinar of APOS ERC. Finally, I recognize my ERC member, Dr. KLN Raju, is also here. Again, another silent spectator.
I probably I'm just listening to the questions that are being asked. Like whatever comes to my mind, the question is being asked by Madam and Sir. So
yes.
I can just
I'm very happy. All
comfortable
the
listening.
questions, both Dr. Sirisha and Dr. Vengopal Reddy, as well as our Dr. Tarkeshwara, they have really extensively covered all the questions. Nothing is left behind. Thank you very much, and good night
Thank
all.
you, sir. Thank you for the opportunity.
Thank you, sir. Thank you, sir.
Good night, all of you.
Thank you very much.
Thank you,
Thanks,
sir.
Good night, sir. Good night, all.
Good night.
Thank you, sir.
Thank you, sir.